Hello, everyone, and welcome to chapter 19, where we're going to talk about the heart. So, a quick overview of the cardiovascular system. So, cardio, heart, vascular vessels, and we're only talking about the heart and the blood vessels when we're talking cardiovascular. When we're talking circulatory system, we're talking about the heart, the blood vessels, and the blood. So, what do you circulate? You circulate the blood. That's a good way to differentiate the two. So, definitely know the difference between cardiovascular and circulatory. So, talking about the location of the heart. So, the heart is not directly centered, it actually sits slightly to the left. The line right down the center of the sternum is called the midsternal line, and the heart is just a little to the left of that. So remember, we're looking patient right, patient left. And it sits just south of the second rib. So your first rib is just off of your clavicle, your collarbone. Your next rib, right under that, is the second rib. So right under the second rib is where the heart sits. And it goes all the way down to right above the diaphragm and behind the sternum. So midsternal line, it's a little bit to patient left right here, below the second rib, and then right on top of this diaphragm. The PMI, the point of maximal intensity. So we're not talking about mortgages with PMI in anatomy. We're talking about the point of maximal intensity. And so this is when, for example, a doctor has a patient lean forward, brings that heart right up to the ribs, and you can hear a really good strong beat. You can hear the valves a lot better, especially the mitral valve. So we'll talk about that. And that's your point of maximal intensity, where you can hear the heartbeat the strongest. On thin people, if they are laying on their back, you can actually see their chest moving with their heartbeat. So for example, if the chest is moving with the heart beating dead center, that patient could potentially have a collapsed lung that has caused that heart to shift. So it's really interesting, knowing the location of the heart, where it's supposed to be, and figuring out, problem solving different things based on that. So again, remember, we're looking at patient left and patient right. So your left's and the right's got to flip. So you have the pericardium. So that's the covering that goes around the heart. And it starts to fuse with the pleura. So the pleura is the lining around the lungs. So we'll talk about that more in respiration, or in the respiratory chapter. Just below the heart, again, we have the diaphragm. And there are ligaments as connective tissue that link the diaphragm to the heart, so the heart doesn't bounce around everywhere. We have the pulmonary trunk. So remember, anytime we talk pulmonary, we talk lungs. We're going to get into pulmonary arteries, and this is heading away from the heart and into the lungs. The superior vena cava has blood going in from the head and left arm, and then the head and the right arm, and they join together and bring that blood to the heart, not bring the heart to the blood. My apologies. They join together and bring blood back into the heart. So then we have the aorta right here. We have the ascending aorta going up, the arch of the aorta, and then the descending aorta peeking through right here, going down. And then we've got branches going to the head and the arm. So This is a cadaver heart, so you can see the lungs here. You can see the pulmonary trunk going to the left lung right here. But that's the biggest piece that you can see here: lungs, heart, and the pulmonary trunk going towards the lungs. What you see on the x-ray here, we call a heart shadow. That is what's blue. Remember, x-rays show really dense objects really clearly, so the bright white is going to be your densest object. Here, the bones are going to show up bright white. And an enlarged heart would actually show up really high, or a little bit more to the left or something on an x-ray, but we typically don't use x-rays to look at hearts. So this just outlines what we should be able to point out in an x-ray. The thoracic cage here outlined in blue. Heart shadow, which we just discussed. We've got the aortic arch right here, which is hard to see because this section actually layers over top of the spine and everything else, but the aortic arch is located right there. And then we've got the diaphragm down here. This is a transverse view, a cross section, if you will. You will never get an MRI or CT of this person in this position because this person is face down here. So notice where the vertebrae is. That's the back. So once you can locate one item, you can orient yourself in how this person is positioned, so you can get your left side and your right side, your posterior and your anterior figured out. And then this person, like I said, is laying face down. So we've got right side over here, left side, front, and the back. But once you can figure one thing out, so you see the thoracic vertebrae here, think about what's next to it. So use just use what you already know, anatomically about what's going to be next to the vertebrae to kind of figure out like where you're located. Another trick is to always look at the reference image. So that's this image right here. And then you can figure out kind of which section of the body you're looking at. So if you ever have to label something like this, usually there's going to be a reference image involved. So just keep that in mind. So we've got our vertebrae here. We've got our spots of rib right here. Notice they are the same color as the vertebrae. So you can kind of figure out that those are the ribs. What's inside of our rib cage? Lungs, right? So you can figure out that these are going to be your lungs that you're looking at. And nestled between those is the heart. So this round spot right here, this beautiful circle right here, that is actually the aorta. It is a thick and hefty artery, and they actually stay popped open even in death. So in the different cadavers that we're going to use for lab purposes, you're going to be able to easily find and label the aorta. This little hole with the spots next to the aorta, that is your esophagus. So boom, that esophagus goes straight down between all of it. If you'll notice from this image, your left lung will always be smaller than your right lung, and that's because your heart sits right there slightly to the left, and that lung is a little smaller to allow space for the heart. So if you don't know orientation, look at lung size too for identification purposes, and you'll know what side you're looking at, if that knowing that left lung is smaller. All right, so generalized circuits. So remember the rule of thumb: arteries go away from the heart and veins go to the heart, right? So how does blood flow through this whole thing? What direction and where? So this is something to really, really pay attention to. You will have to trace a drop of blood through the heart on your exam, whether that's in lab and in lecture, you will have to trace a drop of blood through the heart. We have two main circuits. We have the pulmonary, which is to and from the lungs, and we have the systemic circuit, which is to and from the rest of the body. So your heart has four chambers. It has the atrium and ventricle on the right side, plus an atrium and ventricle on the left side. Your pulmonary trunk comes out of the right ventricle, and it splits into the pulmonary arteries and into the lungs. When it goes here, that's where gas exchange happens. So CO2 goes out, O2 comes in, and you come out with blood through the pulmonary veins back to the left atrium. Left atrium to the left ventricle, then out of the ascending aorta, arch of the aorta, descending aorta, and then the branches that go to the head and arms. And then the rest head south through the descending aorta, through the chest cavity, the abdominal cavity, and down the legs. And it'll split down the legs too, where it's dropping off oxygen, dropping off nutrients, picking up carbon dioxide, waste, fluids, water at the capillary vessels. And then you start heading back through a vein system. So to the inferior vena cava from the bottom half of the body, and the superior vena cava from the top half of your body. Both of those go into the right atrium, then the right ventricle, then back out to the lungs again. So this is really, really important. Study this. Remember that arteries go away from the heart, veins return to the heart. Arteries carry your super clean oxygenated blood, and veins carry your dirty, low oxygen blood. So we briefly mentioned the pericardium. It has two layers. So in this image in the bottom right corner, if you punch through a balloon, you'd feel the outside and the inside, and that's how the pericardium works too, right? So the heart basically sits where the fist is, and then you have the inside layer of the pericardium right against the heart, and the outside layer of the pericardium. And then where this little air pockets are in the balloon that are left, what's left in that area in the pericardium around the heart is just a little bit of fluid. So if you hear that someone has too much fluid around the heart, it means they have way, way, way too much fluid around the heart, and it's compressing the heart. These layers are called visceral layers. So remember, visceral layers touch the organ, parietal layer, these layers are called visceral layers and parietal layers. So the visceral layers touch the organ, just like, viscera and your digestive system and everything we talked about gross anatomy wise. And then that parietal layer is the layer that lines the inside of the wall. So we have our visceral pericardium, and we have our parietal pericardium. The heart muscle itself is called the myocardium. The cardiac muscle is super twisty. We'll talk about cardiac muscle a little bit more towards the end of this lecture. But it's super twisty, so when the heart contracts, it can squeeze like a dish towel. It can squeeze the blood all the way out from the bottom. It can squeeze the blood down from the top, and it's double pumping this way, that lub-dub, right? So your cardiac muscle is going to be different from your smooth muscle or your skeletal muscle, and we will talk about that a little bit more. So this slide, right? This slide has a lot going on. Let's talk about the chambers first. Okay, so we have, on top we have the left atrium, and we have the right atrium. And then on the bottom we have the left ventricle, and we have the right ventricle. The left ventricle wall is much thicker than the right ventricle wall. And why is that? We will talk about that a little bit more. Um, we're going to just talk about labeling right now, though. This is the pulmonary trunk right here. So trunk, anytime you see that, it means it's going to branch later. We have the left pulmonary artery that goes to the lungs. So pulmonary lung goes to the left lung specifically. Then the right pulmonary artery here goes towards the right lung. Then we go back to the heart with the left and right pulmonary veins. So those bad boys are going to be right here. And this is a little bit misleading on where they deposit at, but they are both going to deposit, they're both going to dump right into the left atrium, so right here. So these right pulmonary veins go towards the back, and you'll see a backside of this picture in a few slides where you can see them attaching and dumping into the left atrium. At the arch of the aorta, you have the left subclavian artery, the left common carotid artery right here. So subclavian here, common carotid here, and the brachiocephalic trunk. So remember, trunk means it will branch later. And that is that little section. Let's go back to the walls. So blood from the left ventricle goes through the aorta and into the whole body. And then blood from the right ventricle goes out through the pulmonary trunk and directly to the lungs. So which side is going to need more pressure? Is it going to be the left ventricle, or is it going to be the right ventricle that's going to its neighbor? It's going to be the left ventricle, because the left ventricle is going to the whole body. There is more pressure that requires that muscle to move, and that's why the left ventricle has such a thicker muscle wall right here, and why the right ventricle is thinner. So if you don't know what you're looking at when you're looking at the frontal section of the heart, just remember that the left ventricle has a thicker muscle, because it's got to push blood through the whole body. The right ventricle's got a thinner muscle where it goes right next door to the lungs, right? Again, this muscle is thick. It has to push blood all the way to your head and then all the way to your feet as well, and have enough power to bring it all back. So really tall people, they will have a slightly overgrown heart, because their heart tends to work extra hard to send blood through the whole body. And really tall people also are genetically predisposed to having some heart conditions later in life because of this. All right, next, moving on to valves. So valves keep our blood going in one direction, and we call these one-way valves. It's hard to tell here because they're cut in half, but let's at least discuss what they do. So this bad boy, our mitral valve, our bicuspid valve, our left atrial ventricular valve, it's called all of these things. This one's going to be the easiest to remember because of placement, right? It's between the atrium and the ventricle, so it's right here. So this is what's cut in half. You'll see it better here in another slide. But these strings right here are called flaps or cusps, and they compress together to keep blood from flowing backwards. You see two of these, bicuspid, two. So remember, one direction. And then the same on the right side, except the right side has three of them. So 1, 2, and 3. So we call this a tricuspid valve, or a right atrioventricular valve. So either one is fine in terms of an exam or whatever, but atrioventricular valve is a good one to remember for placement. And then tricuspid versus bicuspid is good to remember in terms of labeling and what you're looking at, right? So tricuspid might be easier to remember, that it's your right atrioventricular valve or your right AV valve, whatever's easier for you. Right AV tells you location, tricuspid tells you how many chordae tendineae they are, which we'll talk about in a second. But remember, anytime that you are labeling, to differentiate between arteries, veins, and valves, because a lot of these do have really similar names, like your pulmonary arteries, your pulmonary vein, right? You don't want to just put left pulmonary, then you're leaving out a big one, a big informative piece that's going to tell you what that bad boy does. Okay, we have two more valves. We have our pulmonary semilunar valves. So those are right here. They are half moon shaped, and they are going to the pulmonary trunk, right? So remember, pulmonary, lungs. And then we have our aortic semilunar valves right here, which are really hard to see. You actually have to tilt the model to see them in the lab. Semilunar valves, they don't have any strings. The strings are called the chordae tendineae that I just talked about, or tendinous cords, whichever one. Chordae tendineae is what your book calls them, so that's what we'll call them. And their job, again on this bicuspid, tricuspid, or bicuspid, tricuspid, are to act as a tie down or an anchor, like a tie on a tent, to keep everything anchored down so it's not flipping back up, for example, into the atrium. But anyways, you have two sets of these on the left side, bicuspid, two sets, left atrioventricular valve, and three on the right side, tricuspid, right atrioventricular valve. So it's a good cheat code to figure out what side you're looking at again. Why do I keep harping on that? Whenever you're looking at a model or a cadaver heart, it's not going to be laid out like this. You're going to have the whole heart in your hand. You're going to have to look inside of it and figure out what you're looking at, right? And these are just some little cheat codes to figure out what directions we're looking at. Papillary muscles right here, they attach the chordae tendineae. So you can see they're raised up a little bit right there. Trabecula carneae is the lining inside of the ventricles, and that helps strengthen the walls of the heart. And then conversely, inside the wall of the atrium are our pectinate muscles. And then what else do we have left? Last thing is going to be our interventricular septum, right here in the middle. So what does that do? So inside between the ventricles, we have our interventricular septum. And it basically just divides the left side from the right side. It's in the name. Interventricular septum. Divider between the left and the right sides of the ventricle. There's also an interatrial septum that exists, but you can't see it in this picture. Okay, so this is the outside of the heart. So outside of the atria, we have these little flaps called auricles. So auricle of our left atrium, auricle of our right atrium. They are our blood overflows. So as blood is coming back, there's a lot of blood really, really quickly, a lot of blood volume, and these are the overflow pouches. The bottom half of the heart, orient yourself first. How? Find the pulmonary trunk, right? You always want to find the pulmonary trunk first. The aorta is going to go behind the pulmonary trunk, right? And that's going to be our good indicator of where we're at. So this is the front, the anterior of the heart. So down the front of the heart is a set of blood vessels. The left coronary artery, right there, is going around. And then you have the left anterior descending artery right here. And that one's going down, right? Descending, LAD. It's also a good landmark to separate the left side from the right side. The circumflex arteries right here, they go around the left side of the heart, and you'll see more circumflex arteries in the next image. You can't see them too well here. And then the left coronary artery is also kind of hard to see, but it's right below there. Did I say left or right? I meant left if I said right. My apologies. But you can look at the, whoops. I think I just moved my screen. Sorry, I had to pause for a second to realign that again. So the left coronary artery is hard to see, but you can look at the right coronary artery right here, and it mirrors it, right? And the coronary sulcus. We'll talk about what the sulcus is. It's basically just a divot that houses the artery, right? Down the right side and down the left side, we have these marginal arteries. So margin, you can't see the left marginal artery. You'll see it in the next picture. But you can always remember margin means on the side, like the margin on your paper. So your right marginal artery is going to be right down the side, and then your left one back here, just a little off screen. The tip of the heart is called the apex. Sounds wrong, right? Because you hear apex as the top a lot. Apex actually just means point. So the point or the apex is the tip of the heart. The top, where all of the vessels come out, is the base, right? So that sounds opposite, but just remember all the vessels come from the base, and then the apex is the tip, which is the bottom. Seems wrong, but it is what it is. And the best way to remember is just apex, tip, and then base, basically where all the arteries come out of. All the vessels, arteries, veins, etc. A sulcus, like I said, is a groove that the artery sits in. So the coronary artery is going to sit in the coronary sulcus, right? It's that indentation. So now we've got the posterior view, so the back of the heart. So again, I would find the pulmonary trunk once you flipped it, and look around. I'm sorry. I would flip this over in real life, find the pulmonary trunk, know what I'm looking at, and then look at the back side of the heart for labeling purposes. So you remember how I told you the left pulmonary veins are going to dump into the atrium? So this is left and right pulmonary veins are going to dump into the atrium. This is the visual, so this is where they come in through the back side, how the right veins curved all the way around. All right, this is what that looks like, dumping into the left atrium. Always look at the arch too and see what direction the aortic arch goes, and then you kind of can figure out what side you're looking at too for lab purposes. Sometimes in the cadaver heart, specifically sheep heart that we use, it chops off the vena cava, but this is a good visual, and the models are gonna be really easy to spot all these things. But even in our cadavers, we want to find as much as we can, right? So notice the posterior intraventricular artery and sulcus here. And then here you can also see the coronary sinus and the coronary sulcus that goes in there. And you can see the left marginal artery that you couldn't see before. Right? Boom, right there. Left marginal artery or vein. And vein. Okay. So here we're looking at the valves from top to bottom. So we start at the pulmonary semilunar valve here. And we've got our aortic semilunar valves here. Then we have our tricuspid valve, so 1, 2, 3 here. Our right atrioventricular valve, if you will, and then our bicuspid valve, left AV valve here with our 2. So just knowing the difference between your tricuspid valve and your bicuspid valve, bicuspid meaning left, tricuspid meaning right. So the way that I remember is tri, T-R-I, are all in right, just in different configuration. R-I-G-H-T, tricuspid, so right AV valve, and then our bicuspid by proxy is going to be your left AV valve. If you can figure these two out, you can figure the rest of them out, right? Look at the flaps, the cusps, and you can kind of know what you're looking at. So here's a real aortic semilunar valve. This is a cadaver. One flap's open, two are closed. This space right here is just from the cadaver drying up. In real life, this would be tight. There would be no gaps there. Talking about valves here and how they work. So you'll just want to read through this slide. So AV valves open, atrial pressure is greater than ventricular pressure. So blood's returning to the heart, fills the atria, puts pressure against atrioventricular valves, and those valves are forced to open. As the ventricles fill up, those valves hang limply into the ventricles. As the atria contracts, forces additional blood into the ventricles, right? Well then, the ventricles contract, force blood against the atrioventricular valve cusps. The atrioventricular valves close, papillary muscles contract, and chordae tendae tighten, preventing those flaps from everting into the atrium. So we are looking at an atrioventricular valve, an AV valve. The smooth side is going to be the atrium. The rough side is going to be the ventricle. We have two chordae tendineae, so this denotes the bicuspid valve, so the left AV valve, right? Not right, but correct. So left AV valve, correct. Blood's coming through the atrium, going into the ventricle. As that ventricle fills up with blood, it puts pressure against these flaps and squeezes them together, creating a leak-proof seal. The same thing happens on the right side with the tricuspid or the right AV valve. So these are our seals. That blood's pushing up, boom, leak-proof. You don't want this to leak back in. That would be not what we want to see in normal heart function. So moving on to the semilunar valve, essentially it's the same process, but we're using gravity here instead. So the ventricles are pumping the blood out, denoted by that arrow. They're pumping it out past the valve. They push it right open, and then when the blood comes down to settle, waiting for the next beat, that gravity is going to push the blood against the cusps or flaps of the semilunar valve, forcing them to close, again creating a leak-proof seal. So both the aortic and the pulmonary semilunar valves work like this. So as ventricles contract and intraventricular pressure rises, blood's pushed up against the semilunar valves, forcing them open. So they open. And then as ventricles relax and intraventricular pressure falls, blood flows back from the arteries with gravity, filling the cusps of semilunar valves, forcing them to close. Leak-proof. So this is a important one. Blood flow through the chambers. Study this. Here it's written out. Read through this. So blood enters the right atrium from the superior and inferior vena cava. Blood in the right atrium flows through the right AV valve into the right ventricle, and it forces that pulmonary valve to open. Blood flows through the pulmonary valve into the pulmonary trunk. Then the blood is distributed by right and left pulmonary arteries to the lungs, where it's going to unload carbon dioxide and load up on oxygen. Right? So out this way, out that way. Go to number 6. Blood's coming back from the lungs via the pulmonary veins and the left atrium. Remember, they both dump into the left atrium. The blood in the left atrium is going to flow through the left AV valve and into the left ventricle. Contraction of the left ventricle. So this is happening at the same time as step number 3. Forces the aortic valve to open. Bloop. Now we're on number 9. Blood flows through the aortic valve and into the ascending aorta, where it's going to distribute even to every organ in the body, where it's going to unload oxygen and load back up on carbon dioxide. And then number 11, blood is going to come back to the right atrium via the vena cava. So study this, know this. Here it's all written out. But this is what you're going to need to know. You're going to need to know this cycle regardless of where it starts. So memorize, memorize, memorize. If I say starting at the left atrium, trace a drop of blood through the heart, know that you're going to end where you begin. So if you start at the left atrium, you're going to end at the left atrium. This one starts at the superior and inferior vena cava, and then it ends at the superior and inferior vena cava. But where it starts is where it'll end. So memorize, memorize, memorize this. But definitely know it, because you will be tested on this. So these are the blood vessels that we could not see very well. The left coronary artery is underneath the pulmonary trunk. You couldn't view that in previous figures. Here it's pretty easily labeled. This is blood supply to the heart itself. And then you have 2 branches. You have the circumflex branch that we talked about, and you have the anterior descending, the left anterior descending, so LAD. Another name for that is the widowmaker, and this is one of the fatal places to have a blockage. So when people say that they're having a bypass, it's probably this one that's getting bypassed. This is almost always one of the first places to form a blockage. Critical because it supplies blood to the left side of the heart. So it supplies blood to the left side of the heart, the apex, part of the right side of the heart, and a blockage would disrupt that blood flow into the heart. Angina pectoris. So this is chest pain from partial obstruction of coronary blood flow. So this is not a complete blockage, just a partial, but this is a good warning sign, right? Myocardium shifts to anaerobic fermentation, producing lactate, and thus stimulating pain. So what does this mean? So lactic acid buildup happens. This is called anaerobic respiration after you use up everything after working out, right? This is what causes muscle soreness. Same thing in the heart. So having that muscle pain, you've used everything up aerobically, lactate builds up, and that's what is going to cause your heart pain. So this is a really good indicator that something is happening. Something that's not right is happening. Which moves us on to myocardial infarction, MI, aka a heart attack. So, this is sudden death of a patch of myocardium resulting from long-term obstruction of coronary circulation. So, the cardiac muscle downstream dies from lack of blood flow or from insufficient blood flow. So, there will be a squeezing pain to the left arm and into the carotid arteries, which are up in your neck. And sometimes there'll be a little bit of nausea with this too. Heart attacks can be painless and lead to cardiac arrest. So the heart's not dead, it's just stopped. The electricity has been cut off, basically. This one is easier to fix for first responders because they just shock it electrically, right? If they're fast enough to save that person. So the pressure and the squeezing pain is going to be a little bit more difficult. So this one usually results in open heart surgeries to open those vessels up before lack of oxygen causes irreparable damage to the muscles. So I told you about the muscle differences, right, that you're going to need to know to differentiate cardiac muscle from smooth and skeletal muscle that we talked about in Anatomy 1. So there are a couple differences here. So we have a lot of nuclei. So nuclei of the cardiac cell here in the bottom right picture, all those blue spots, those are the nuclei that have been outlined. So you can trace those back to this generalized image of a cardiac muscle. Several lines that form muscle fibers are called intercalated discs, right here outlined with these little blue markings. Cardiac muscle is the only one that has these intercalated discs, and it's going to be the only muscle that branches too. So here you can see the branches. It doesn't just say one, it branches off. So remember we were talking about the cardiac muscle has to be able to wring out like a wet dishcloth. All of this branching helps it to curve around like that. So skeletal muscle in comparison is completely parallel with no branching. It's going to be a really easy way to spot the differences. They are also striated. So they have banded stripes. So make sure you can differentiate these again from skeletal and smooth muscle. So moving on to electricity, the electrical part of the heart. So there's a little sing-song that we remember: SA node, AV node, bundle branches, Purkinje fibers. If you can remember that, you are going to remember the conduction system of the heart. And that's important for this entire next section. So first, your sinoatrial node, your SA node, fires in the wall of the atrium. So find number 1 in the picture, right there. Number 2, excitation spreads through atrial myocardium. So, in other words, the atrium muscle down the walls of the atrium, right? Or the atrium excites down the walls, which triggers, number 3, the AV node or the atrioventricular node. So now the AV node fires down here at the bottom of the atrium. Number 3. 2. Number 4, excitation spreads down the AV bundle. So we call these bundle branches, right? So the bundle goes down through the center of the septum and it splits at the bottom of the heart and it goes up both sides of the heart. So bloop, going back up both sides of the heart through a subendocardial conducting network, which we are not going to call that. We're going to call them Purkinje fibers that distributes this through the ventricular myocardium, right? And over and over and over again. So remember, SA node, AV node, bundle branches, Purkinje fibers. SA node, AV node, bundle branches, Purkinje fibers. And you will never mess this up. So 1, 2, 3, 4, and 5. 1, 2, 3, sorry, 1, 2, 3, 4, and 5. SSA node, AAV node, bundle branches, Purkinje fibers. You'll remember it forever. If you don't remember anything else, you will remember that forever. So this is an intro to an EKG, an electrocardiogram. You'll see EKG and ECG used interchangeably. It's the same thing. This is a generalized graph of how it works. This isn't necessarily an EKG. So when there's a particular amount of energy coming through, it's called a threshold. So that's our black line down the middle right here. That is our threshold. This particular amount of energy. Then you'll have ions starting to change. So remember, ions are sodium, calcium, potassium in this image, or in this pacemaker physiology. You remember the sodium potassium pump? This is where you'll actually come to use it. This is where it comes into play. So you did not learn it for no good reason. So here we have slow influx of sodium into the cell membrane. And once you hit that threshold, you have enough power to start that reaction. So there's enough sodium now to start this reaction. We started at negative 60 millivolts. We've added enough sodium until we got to negative 40 millivolts. So then a bunch of calcium and sodium are going to come in to really fast, reaching this 0 millivolt area. And then we're going to have a bunch of potassium flow out, where we have to bring sodium back in slowly. So you get enough energy, boom, to juice again. So sodium's coming back in slowly, boom, juice up, and then our action potential going back down. So down here, this is what we call the pacemaker potential, where we have a slow influx of sodium. And where we have potassium leave, we call that our action potential. So all of these ions have a positive charge. And once we hit a charge that's too positive, we're going to have some of that positivity flow out, right? So that's where potassium leaves us. And this is what happens over and over again in a heartbeat. So we'll talk about that a little bit more. So again, we start at negative 60 millivolts with slow sodium going in, and we are gradually depolarizing. So less polar, more positive. So we're going up. As you're putting these pluses in, these sodiums that are positively charged, you're making that less negative. So we're going from negative 60 millivolts, adding sodium. Once we get to negative 40 millivolts, so we're getting more positive, right? Less negative. That's where the calcium and the sodium really rush in and go all the way up to 0 millivolts. So now we've gone from negative 60 millivolts, negative, to 0 millivolts very rapidly. Remember, the positives are going to cancel out the negatives, so don't let that confuse you. We're going through depolarization, going up. Well, then the potassium starts to leave, repolarizing it, making it more polar, more negative, going back down to negative 60. So repolarization is going down. Depolarization is going up. So depolarization is taking the negatives out, making it more positive. Repolarization is taking the positives out, making it more negative. And once the potassium channels close, the pacemaker starts over. So the SA node starts this whole thing. That's the pacemaker. The SA node firing starts it all. So see how all of these puzzle pieces are starting to fit. During this whole chapter, the whole rest of this chapter, just remember SA node, AV node, bundle branches Purkinje fibers. And that's one heartbeat. So again, EKG, ECG, it's a normal electrocardiogram. Either abbreviation you use is interchangeable. Both are correct. So all of these bumps have names. We have our P wave first. Then we have QRS, so the Q, the R, and the S, we call that our QRS. We lump it together. And then we have our T wave. The flat space is rest. Then we have P again, we have our QRS, and we have our T wave again. And then you can't see it here, but you can see it up here. We have our rest time again. So we have P, QRS, and T, and rest over and over and over again. That's our EKG. The closer together that these are, the smaller the resting rate, the faster the heart rate. The further apart they are, so the longer the resting rate, the slower the heart rate. The taller that the peaks are, the stronger the heartbeat. And vice versa, the smaller the peaks, the weaker the heartbeat. So which one do you think will give a stronger beat, the atrium or the ventricle? Which one goes to the whole body? The ventricle. So because the ventricle has to pump blood through the whole body, it's going to have a stronger beat, it's going to have a higher peak. So the QRS belongs to the ventricle. The QT interval down here is how long ventricles are contracting. And then the PR is how long the atrium are contracting. So this is a picture that goes along with the bumps on the EKG. So you can just read through these. So the atria begin depolarizing here. Atrial depolarization is complete here, where the yellow is. Ventricular depolarization begins at the apex and progresses superiorly as the atria repolarizes, so right here. So depolarization is happening while the atria is repolarizing. And then we have ventricular depolarization completing. And then we have ventricular repolarization beginning at the apex and progressing superiorly. And then ventricular repolarization is complete and the heart's ready for the next beat, right? Big ones to remember. So 1, the atria are depolarizing. 3, the ventricles are depolarizing and the atria are repolarizing. And then 5, where the ventricles repolarize. So remember 1, 3, and 5. And then 2, 4, and 6 come naturally. Again, EKGs, ECGs, they are used interchangeably, but they are the same thing. So if you were to type out either one of these for a test answer or on a quiz or on a practical, both of them would be right. So figure A is a normal sinus rhythm, regular pattern throughout, evenly paced. That is what we love to see. That's great. B, we've got somebody in VFib, ventricular fibrillation, which we're calling VFib for short. That's going to be not so good. So the heart muscle, the bottom side of the heart muscle, the ventricles, are beating erratically here. The electrical signals are all over the place. You can't get a good squeeze, then the blood's not moving anywhere. So the rest of the body's not getting enough oxygen. So that is what's happening in VFib, and that is what an ECG looks like. Very abnormal, we don't want to see that. So remember, SA node, AV node, bundle branches Purkinje fibers. Here we're getting lost after the AV node. So we got SA node, AV node, and then where do we go from here? There's no rhyme, there's no reason. The heart's not pumping. It cannot pump. So this is the hallmark of a heart attack or myocardial infarction, MI. This can be extremely fatal if not stopped. Defibrillation it stops VFib. So you guys have heard of defibrillators. That resets the heart electrically by shocking it. This is what you see in all of the first responder TV shows and movies. Now, this is not going to be a cure for artery disease, but it can allow time to get that patient to the hospital for other further corrective actions. So here we have AV heart blocks. So there's no conduction to the ventricles, so you don't see any QRS. So right here, there are only P waves, no QRS. Here we see the P wave, QRS, and our T wave. So here we're back to normal. Again, SA node, AV node, bundle branches, Purkinje fibers. This is SA node, AV node, nothing. SA node, AV node, nothing. And then we go, again, SA node, AV node, bundle branches, Purkinje fibers here. But missing that QRS is what we call an AV heart block. So there's no conduction to the ventricles and no QRS. PVCs are ventricles beating out of correct timing. So this is premature ventricular contraction. And when you have this, ventricles are beating too early. So that's a big dip right there. That's your atrium ventricles at the same time. So there's no P wave. PVCs won't kill you, but they can cause problems with blood flow because there are no solid beats. This is an irregularity in timing, so this isn't going to happen on every beat. It's going to be pretty inconsistent. All right, so this is a Wiggers diagram. So here we want to look at one section at a time. So this is all happening simultaneously. This is pressure in millimeters per mercury section. This is going to be your ventricular volume. This is your ECG, and here we have some heart sounds. And this is all happening in 0.8 seconds. From purple to purple, right? That's going to be the easiest way to think about this. So these are all happening simultaneously. Like I said, we'll start with blue, then you go to green, yellow, orange, purple, over and over and over again. So let's look at the yellow, for example. Let's look at what's happening here. So the AV valve's shut. Look at the heart sounds. Look at what happens when the AV valve's shut. You can see a big heart sound there. When the blood is out in the pulmonary trunk, so number 3, and back to resting on the pulmonary semilunar valves, so number 4, you're going to get that second sound. So the sounds occur, see right there, in the purple, right here, purple, purple sound, yellow, yellow sound. So what's happening here is the sounds are happening when the valves are being slammed shut. So that's a really cool significance of this graph. S1, your AV valves shut. S2, your semilunar valves shut. So S1 right here, AV valves shut. S2, semilunar valves shut. And that's what gives you that lub and that dub. So S1 at S right here on the QRS graph is going to give you that lub sound, and then S2 at the end of the T on the ECG is going to give you that dub sound. So we got lub dub, lub dub, lub dub right there. And this is a nice little color-coded way to look at it. Up here at the top, aortic pressure is the red line. So pressure's at the top. Pressure is highest when the ventricle has squirted all the blood into it. So big spike here in the orange. So the orange is the fill up. The rest is the blood draining out into the rest of the body. There's a summary of everything that's happening right here on the side that you can read through. Remember, SL valve is a semilunar valve here. And when the valve's shut, you get that lub-dub sound. So atria contract in the P wave. Ventricles contract. Pressure's equal. AV valves shut. So S1. And the QRS wave. So all of this happening at the same time, right? When the ventricles eject, that's when the T wave is happening. And when the ventricles relax and the semilunar valves shut, that's when you get the second sound. So you're not getting the second sound during the T wave, you're getting it at the end when the semilunar valves shut. Anytime the valves shut completely, that's when you get the sound, right? So we got lub and dub. And then when the atria refill and fill the ventricles, there's usually a soft sound on S3. That's it, that's a summary. Just remember, valves shut, you get the sound. All right, so overview of volume changes. Normally right and left sides of the heart eject the same volume of blood, even though they are under different pressures. So the left side has the same volume as the right in the ventricle, but the left side is going to pump it harder because it has to travel further. The right side just goes to the lungs next door, so it doesn't have to pump as hard. Congestive heart failure. So results from the failure of either ventricle to eject blood effectively. This usually is due to weakened heart from muscles dying after a heart attack. So there's valvular insufficiency, so leaky valves, chronic hypertension, congenital defects sometimes, and those are birth defects. Those are defects somebody's born with. And then we have can be congested due to the blood pooling and not pumping out. So that is what the congestive heart failure is referring to. Typically you just hear heart failure these days, not congestive. So this is left ventricular failure, and this happens when the left side's not working right. So blood is backing up into the lungs, causing pulmonary edema. So blood flow into the lungs, nothing's coming out. So fluid starts collecting out the capillaries, filling lungs up, and that's what causes that pulmonary edema. So lungs are filling up with water, drowning in their own fluids, right? You are experiencing shortness of breath or a sense of suffocation because you can't breathe because you got fluid building up in your lungs. If the left side fails, you're having lung issues, you're having breathing issues. If the right side fails, blood's backing into the vena cava and causes swelling in other places. So you got blood going in and no blood coming out. So then the same thing happens. Water's squishing out at the capillaries, and you end up with issues like swollen tissues, ascites, which is fluid in your abdominal cavity, swelling of the feet, swelling of the ankles, and either one of these can lead to total heart failure. Moving on to some math. So cardiac output, I don't like that that's SCO because that makes me think carbon monoxide, but in this case, we are talking cardiac output. So this is the amount injected by each ventricle in 1 minute. How do you measure it? You measure it by multiplying heart rate with stroke volume. What is stroke volume? Stroke volume is how much blood you're pumping out. So most of the time, you've got about 4 to 6 liters per minute at rest. Red blood cell leaving the left ventricle will arrive back at that ventricle in about 60 seconds, right? It takes about a minute. So it circulates your entire body that quickly. A lot of vigorous exercise increases your cardiac output to 21 liters a minute for a super fit person, up to 35 liters a minute for those elite athletes. Your cardiac reserve is going to be the difference between your maximum and resting cardiac output. So this increases with fitness and it decreases with disease. So increase with fitness, your resting cardiac output would be greater. Decreasing with disease, if your heart's not pumping very well, it's going to lower your cardiac output. So heart rate, definition of a pulse, that's the surge of pressure produced by a heartbeat that can be felt by palpating a superficial artery. This is a big list of different locations: neck, wrist, groin, behind the knee, lateral ankle, foot. The neck's going to be where you can feel it the strongest. The wrist is going to be where most people will measure your heart rate. A lot of people won't let you at their neck, but you can measure your own heart rate at your neck, right? Infants are going to have a high heart rate, normal, 120 beats per minute for an infant. Young adults are going to average somewhere between 72 to 80 beats per minute. And then as you age, your heart rate rises again, especially in elderly patients. Usually this is because your blood vessels are going to be a little bit stiffer. It's going to make your heart work a little bit faster. Tachycardia is fast heartbeat, over 100 beats per minute. So some of the causes can be due to stress, anxiety, drug use, heart disease, fevers will increase your heart rate. Loss of blood or damage to the myocardium. Your heart's going to beat faster to move the same amount of blood to the body. All right, bradycardia, conversely, is low heartbeat. So less than 60 beats per minute. In your sleep, your body temperature lowers. So even if you're sweating in your sleep, your body temperature is still lowered. And that's when you'll have, a heartbeat less than 60 beats per minute. A lot of our elite athletes, they also have heartbeats that are going to be lower than 60 beats per minute. And then we have chronotropic agents. So remember, chrono always refers to time. Chronos is the god of time. So chronotropic agents, we have positive and negative ones. Anytime we talk about these, we're talking about drugs that are used to raise your heart rate or to lower your heart rate for any reason. So positive raises the heart rate, negative chronotropic agents lower the heart rate. Stroke volume, so the other factor in cardiac output besides heart rate is stroke volume. So this is volume injected with each heartbeat. Here, systolic is at peak contraction. Diastolic is at rest. That's just what systolic and diastolic means. Systolic, peak contraction, diastolic, at rest. So to get your stroke volume at rest, you subtract the volume you still have once contracted, and that's what stroke volume is. So total filled up volume minus after you've ejected volume. So your relaxed full volume minus post ejection volume of blood. Electrolytes play a big part in this as well. Electrolytes are super important for normal function overall. Potassium has the strongest chronotropic effect on the heart. So hyperkalemia, so too much potassium diffuses into the heart cells, and you have myocardium that's less excitable. You're going to have slower heart rate, irregular heart rate. Conversely, hypokalemia, so too little potassium, and your cells are hyperpolarized and require increased stimulation. So hyperpolarized cells, they don't want to beat. Calcium, so we have hypercalcemia and hypocalcemia. Hyper, too much, it decreases your heart rate and contraction strength. Hypo, too low, increases your heart rate and contraction strength. And all four of these can be fatal. And I know this was a long one, but this concludes our chapter over the heart. I hope you enjoyed.